Okay. So first thing, today we are going to talk about wrist ultrasound and dorsal side, not the ventral side. Just a minute. Hmm. So what are the structures? What are the structures in the wrist? So it is bone and joints if we consider from the deep to superficial. So first it is the bone and joints, and then comes ligaments. Ligaments just above the, because it is the connection from bone to bone. So it is also at a very deeper level. Then after that it is muscles and tendons. And then there is superficially there is retinaculum, and of course there is a fibrocartilage in the ulnar side. There is TFCC. uh, that fibrocartilage also we'll talk about. Okay, so now see, though in the when it is in the ventral side, and we will discuss the same thing, but in dorsal side also, let us see that what is the orientation of the wrist bones. Okay, so here you see, from radial side to annotate. Okay, so I think, so here this is a radial side. Okay, this is radial side and this is ulnar side. So you match with the X-ray picture, and this is the schematic diagram. So remember, from our MBBS days, there is a mnemonic we used to use. I don't know if everyone used or not. That is, she looks too pretty, try to catch her. So she looks too pretty, the proximal row of all the bones. So as for scaphoid, looks means lunate, and then triquetrum and pisiform. Okay, she looks too pretty, and try to catch her, this trapezium, trapezoid, capitate, hamate. Okay, so this is the distal row. So if we can just remember that four bones in the proximal row and four bones in the distal row. But things are not that easy. There is, it is not a parallel line. So how it is, you actually see carefully that it looks like a T and a C. So let us see in this way. Say that this is a T. So this is a T and this is a C. Okay, this is a C. So we can say more like this is a T and this is a C. So this is the way actually how the bones are oriented in wrist. First thing. Second thing, there is one more thing, that is, these are not in the same transverse plane or same sagittal plane. So from both the sides of the wrist, bones are a bit concave shape. This shape is, they are like not in the same plane. How? So pisiform bone, it is a bit over the triquetrum. So you can say that first floor and ground floor type of thing. These three bones are down, I mean, at one level, but this bone is actually at this end over the triquetrum. Similarly, trapezium and trapezoid. So here also trapezium is the major bone and trapezoid is a bit at the upper level of the trapezium. Okay, but then both the bones, so all the bones here not in the same level. Why I am saying this? There is the importance of this thing, because when we will put our ultrasound probe, you cannot prove in a put the ultrasound probe in a curved way. You have to put in a straight way. So every bone, when we have learned that proximally it is the scaphoid, lunate, triquetrum, pisiform, you will not be able to see, because they are not in the same line, they are curved. Okay, so this holds true for the upper row also. Now some more important thing. So here, this is the radial side, and this is the ulnar side. So what are the bones actually articulating with the radius? So these two bones, okay, scaphoid lunate, they both have articular surface over the radius. So this is also an important part. Okay, in the ulnar side, you see there is a big gap. There is a big gap, okay, from the carpal bones and the ulna. So this is also important while seeing the ultrasound, while putting your ultrasound probe. So you expect a gap. You do not expect a articular surface in this side. Okay, so this is one important thing. Next, if when we are putting the ultrasound probe in a longitudinal way, say I am putting in the middle finger, over the middle finger I am putting my probe in a longitudinal axis, then what are the bones I expect to see? So here you see, you will be seeing the here it is the metatarsal, then comes capitate, then comes lunate, and then comes radius. So this part is also important. So before starting the ultrasound part, remember all the bones: proximal row, scaphoid, lunate, triquetrum pisiform; distal row, trapezium, trapezoid, capitate, hamate. But still, they are not in the same line. They are forming like T, and above it is C, because capitate is a very big bone. So already I have talked about it, that what is the alignment and how the bones are, you can see. So there are some bony landmarks, which is also very much important. As already I have showed that this is the So already I have showed this is the radius. This is the radius articular side. This is the articular surface. So you can see that this surface, lateral surface, is for scaphoid, and this surface is for lunate. Okay. So it articulates with both the bones. Another important thing is lister tubercle. Lister tubercle. So this is also found at the lower end of the radius and in the dorsal surface. In the dorsal surface, in the lower end of the radius, you can palpate it. You can start from the styloid process of radius, and then you can gradually come medially to feel this lister tubercle. This tubercle is very important. Okay, there is another tubercle, that is scaphoid tubercle, that is actually coming a bit in the front side. That is not important today, but some previously, when uh, I will tell while demonstrating, previously by landmark technique, when we used to identify the area of first quadrant of tendons, then that was needed, scaphoid tubercle. Listed tubercle, okay, scaphoid tubercle, both the styloid process of radius and ulna is palpable. See, after you have understood the orientation of bones, how it is there, so you see, here it is just the opposite thing. Here in the right side, scaphoid has come. Scaphoid is in the right side. So here you can see there are small ligaments. These are called intrinsic ligaments of the wrist in the carpal area. So all the bones, all the carpal bones, they are attached to their adjacent bones. So there are multiple small ligaments, but whether how can we remember so many ligaments? So we don't need to remember all those ligaments. So which are the important ligaments here? So as I told you that from the this is again the radial side, and she looks too pretty. So here between scaphoid and lunate, there is one ligament, scapholunate ligament. So this scapholunate ligament in this area, it is important. It is prone to injury. So it is one ligament, and another ligament we will be able to see, that is lunotriquetral ligament. So this area, lunotriquetral ligament. So these two ligaments are sufficient for seeing, because they are most important when a injury is concerned. If there is an other ligament injury, of course MRI is there for gold standard to see very small any injury is there or not. These are very small ligaments. All ligaments you cannot see under ultrasound. Okay. Uh, okay. So this part I will show by ultrasound. Next part, let us come to the tendons. So here what happens, when we try to memorize all the tendons, then first thing we need to know, there are 6 compartments in our wrist. Okay, from the scaphoid side, means radial side, here it is the radial side. From here we will try to understand that what are the ligaments. Okay, so here in the radial side, first compartment is in this side, in one side of the radius. Okay, here this is the 6th compartment, and in between them we will find all other compartments. Here is, say here it is the Lister tubercle. Okay, Lister tubercle. So another compartment is here, which is 2, and just by the side of the Lister tubercle it is 3. Then comes compartment number 4, and just above the radioulnar joint, distal radioulnar joint, there is another compartment, that is compartment number 5. So here what are the things for remembering? One thing is, there is a Lister tubercle, which is our starting point of ultrasound also, and here also for understanding purpose we must know that Lister tubercle is very important. And then just by the side of the Lister tubercle it is compartment number 2, and in this side, in the ulnar side, it is compartment number 3. So this much we can understand. Okay, and compartment number 5 is just above the radioulnar joint. 1 and 6 already we have understood that it is, 1 is above the radial styloid process, and 6 is above the ulnar styloid process. So 1, 2, 3 is already understood. In between there is a big tendon, that is compartment number 4 for digitorum tendons. So let us see what are the tendons. I will show it here. So this one is extensor retinaculum. I am hiding it at present. We are not talking about that. So here let us see. Remember, here there are 2 tendons. One is APL, abductor pollicis longus, and another tendon is EPB. EPB. Just a minute. I will make it even bigger. Okay. So this is APL and EPB. Okay, abductor pollicis longus and extensor pollicis brevis. So this thing, this much you have to just memorize it. Remember, this is our pollex, this is our index, and this is our pollex finger. Okay, so anything which is their pollicis, it has to go to the pollex finger, means thumb. Okay, so this is APL and this is EPB. So P is there. Then comes there, this, in this pollex there is the third compartment tendon is also coming here. This is EPL. EPL. So I write it here. It will be better. Okay. So APL, then comes EPB. This is the first compartment. Okay, already we have seen this one and this one. Now comes third compartment, which we are showing now. This is EPB. EPB. Now, what is the second compartment tendon? Second compartment tendon is here. This one, ECRL and ECRB. So remember the common extensor tendons. Common extensor tendons comes from the extensor side, and they all insert in the extensor. They all come in the extensor side of the wrist and insert in different areas like metacarpal or phalanges. Okay, so here only 1 and 3, APL, EPB and EPL. Actually this is EPL, APL, EPB and EPL. These three tendons, they do not come from the just above, they do not come from the common extensor tendon. Okay, I think I will show by the picture, that is better. Clear all drawings. So this part you have to just remember. Okay, so here remember, first compartment as I told you, APL and EPB. Third compartment was EPL. Okay, extensor pollicis longus. This is not working. Okay, and see one thing, just below the first compartment and third compartment, there are two tendons. So this is ECRL and ECRB. Okay, so first compartment, second compartment and third compartment. I am trying to show you the 3D orientation of the tendons. See, ECRL and ECRB, it is coming straight, and it is in the second layer, but they are being traversed by three tendons. So what are they? That is first compartment tendon, APL and EPB, and third compartment tendon, that is EPL. Okay, so first, second, third you have already understood. Okay, now fourth compartment tendon. Let us see what are the fourth compartment tendon. So it is the extensor digitorum. Of course, there is another tendon, that is extensor indicis. So extensor indicis and extensor digitorum, they are the fourth compartment tendon. Now comes the fifth compartment tendon. So fifth compartment tendon, as I said, it is just above the extensor digiti minimi, and it comes just above the radio-ulnar joint, distal radio-ulnar joint. And sixth compartment, extensor carpi ulnaris, that is the above the styloid process of ulna. So mainly the most important tendons are 1, 2 and 3, and also 4 you can say. So mainly 1, 2, 3 you must remember. So now just a broader orientation to give you. Okay, so just you see that here this was the ECRL and this was the ECRB. So though ECRL is not a part of common extensor tendon, but it was also from above the elbow. From above the elbow, this tendon started, and this tendon also started as a part of common extensor tendon. So remember the quadrant number 2. Quadrant number 2. That is, there you will find ECRL and ECRB. Okay, so that will traverse the carpal bones and insert in metacarpal and base of the metacarpal. Likewise, other tendons like extensor digitorum and extensor digiti minimi and extensor carpi ulnaris. So they are also coming, they are also traversing the carpal area and inserting in the respective areas like metacarpal or in the phalanges. So if I remove all these tendons, then let us see what is left. Common extensor tendon I am removing now. ECRL removed, ECRB removed, then comes extensor extensor digitorum removed, then comes extensor carpi ulnaris removed, and then comes extensor digiti minimi removed. So now you can see that compartment number, you can remember compartment number 2, compartment number 4, 5, 6, all these tendons, all these muscles actually, they started from above the elbow, and they crossed the carpal region or wrist, and they inserted in the hand. But these APL, EPB and EPL. So this is APL. You can see it starts in the forearm. Okay. This is EPB. This also starts in the forearm. So these APL and EPB is a compartment 1 tendon. Okay, compartment 1 tendon. Now comes compartment 3rd tendon, that is EPL, extensor pollicis longus. I am hiding this. Okay. So you can understand that APL, EPB and EPL means compartment number 1 and 3, they come from the forearm and they traverse over the carpal region and insert in the metacarpal or phalanges. So why it is important? Because these muscles, when we track down that how it is formed, the anatomy, we must remember that which are the muscles which is coming above the elbow and traversing the wrist, and which are the muscles only coming from the forearm and traversing the wrist. Okay. Now this is extensor indicis. This is also a small tendon muscle starting from the forearm and coming to the index finger. So this is also part of compartment number 4, where the part of with the extensor digitorum. Okay. So with this much of anatomic knowledge, let us go forward. Okay. So now you remember all the, so this is from this side to this side. So radius, you can understand, left side is radius. Okay. APL, EPB, then ECRL, ECRB coming from above the elbow. 3rd EPL.
Are you trying to show something with the PPT because you haven't shared it?
Oh, I have not shared. Just.
The demonstration you have already done. Right now, what you are talking, are you trying to talk with PPT?
Yes.
Then
Yes,
you share PPT.
I'm trying to share the PPT only. Okay. Yeah. Now you can see.
Yeah, it is visible.
Okay. So already, as I told you, that this is a cross-sectional view only. So this is the radial side, scaphoid side, and this is the ulnar side. So here you can understand from above, if we see, then this is the extensor surface. Okay, extensor surface, dorsal surface of the wrist. So you see that in your own hand, you try to imagine that APL, EPB starts from the forearm and forms the compartment number 1. But ECRL, ECRB, they start above the elbow and forms the compartment number 2. And then comes compartment number 3, which is EPL. This is also coming from the forearm only, and they are Therefore, it is forming the compartment number 3. Now comes compartment number 4. As I told you, there is extensor indicis, last muscle I showed, that comes from the forearm only and traversing above the your forearm, the above the carpal bones. So this is extensor indicis, but mainly extensor digitorum, that also comes from above the elbow and going to the hand. So this is forming the compartment number 4. Extensor digiti minimi, that is for compartment number 5 and just above the radioulnar joint. Extensor carpi ulnaris above the uh, styloid process of ulna, and this is forming the 6th compartment. So this much you must remember actually, then only we can proceed for diagnosing a patient. Now comes retinaculum and synovial sheath. Already I have talked about, already from deep to above if I come. So first it was the bone, and then comes bone and joint, and then we talked about ligaments. Only 2 ligaments are important here, as I told you. And then comes tendons, muscle and tendons, and then it is the important is retinaculum and synovial sheath. So here one important thing is synovial sheath. Of course, if there is no fluid, it is very difficult to see. It is very difficult to see a synovial sheath there above the extensor tendon. If there is a effusion, then only you can see that just around the tendon there is fluid collection, and you know that okay, synovial sheath is there. Okay, and extensor retinaculum. So extensor retinaculum is needed to hold all the tendons together in with the bone. Okay, so here you can understand. So they have bony. I mean, it is inserted in the bone. So here uh, this extensor retinaculum is not a straight line. You can see the radial side is a bit proximal. Okay, radial side is a bit proximal and ulnar side is a bit distal. So it is obliquely placed. It comes from the radius. It comes from the radius, and here it is the triquetrum and pisiform where it inserts. So it is nearly 4 millimeter thick width is there, nearly up to 4 millimeter width is there. So this is a oblique orientation of retinaculum. We can see this part, retinaculum. One important thing while we will see under ultrasound, APL and EPB. I told you that this forms the compartment number 1. Though APL should have been one tendon, but it has multiple slips. Okay, up to 3 or 4 slips has been found, and EPB and other tendons have only one slips only, but APL have multiple slips. So this is also important. Why it is important, I am saying. Okay, another. Okay, next slide, just I tell you. Just a minute. I think I have written there. No. So anyway, why it is important that okay, septations, there are, it is due to the septations. What happens that when a tendon has multiple slips, there it is possible that there are septations between the tendon slips. So you want to give an injection intervention around the tendon, but it may not reach the full tendon. I mean, the intervention may be difficult. So these septations are found inside the APL also, and other areas like extensor retinaculum, as I showed you. From extensor retinaculum, there are septas which actually separate all the extensor digitorum tendons, and others also from all the compartment. These compartments are formed as there are different septas from the extensor retinaculum. So they form different compartments. Okay. So these are important for intervention purpose. Now let us see the nerves which is important here. So neuralgia wise, one you can see the radial nerve, superficial radial nerve is coming in this area over the wrist. It is above the compartment number 1. Compartment number 1, when you come from distal to proximal, so they come from the front side to dorsal side. You go from distal to you go from proximal to distal, from elbow side to wrist side. When you go from proximal to distal, you can see that nerve comes from front side to wrist side, I mean palmar side to wrist side, dorsal side. Okay. So this superficial radial nerve, which is a sensory branch of radial nerve, so this can cause entrapment neuropathy and severe pain. Now comes, of course, there is one motor nerve also, which is called dorsal interosseous nerve. This, which is a branch of posterior interosseous or dorsal interosseous nerve only. This continues up to the wrist in the compartment number 4, but it is a purely motor nerve. So hardly we need to do anything, but you must know that where this nerve is, so that you don't injure in some other procedure. Okay, so nerve wise, these two nerves are found in the dorsal compartment of the wrist. This already I showed you that if we with the middle finger, on the middle finger, if we put our probe in a longitudinal way, then what bones we will see? So we will see the capitate and lunate. Okay, mainly. Okay. Yeah, this is okay. Lastly, TFCC is a fibrocartilage. TFCC is a fibrocartilage, but then in TFCC, this fibrocartilage, though it is not completely in the dorsal side, but still it is, as I showed you, that ulna and carpal bones, they have gap. So what is filled by that gap? So it is filled by a fibrocartilage complex. So that fibrocartilage, we call that TFCC, triangular fibrocartilage. But this TFCC is actually, when it is injured, it is not injured that fibrocartilage only. It has multiple, it is considered as a complex. So it can have injury to the other parts also. So what are the things in the complex? There is some ligament. There are some ligaments, and there is some meniscus homologue. So multiple things are there in TFCC. The most important thing, so this is from a paper only. They found that different parts are there when we are considering TFCC. So extensor carpi ulnaris, ulnar collateral ligament, and of course there is a fibrocartilage, triangular fibrocartilage is there, and one so all the things, some ligaments are there, small ligaments are there. So all the things together, they make the TFCC complex. So with ultrasound, we can only suspect that whether we can see only partly of the TFCC part. We cannot see the complete TFCC. So MRI remains gold standard in TFCC injury. But you can of course see that whether it looks that like meniscus in the knee, we can see only a part of that. So this fibrocartilage, we can just see that whether there is any injury, evident injury there or not. So this I will show you. Okay. I think I will complete the, okay. No, I will first take the demonstration. Yeah, I'm just making everything ready for demonstration. In the meantime, if you have any question, please ask me. Okay. Can you see the hand of the volunteer and ultrasound?
Yeah, it is visible.
Okay. 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 So first, as I told you that from the dorsal side, the most important landmark. Oh, just okay, it is there. Okay. Most important landmark is Lister tubercle. Okay. Lister tubercle is not found, it's found on radius. So this is the radius. We can actually palpate the styloid process this side. Okay, styloid process and gradually come to palpate the Lister tubercle. So I can palpate the Lister tubercle here. So anybody can palpate and see where is the Lister tubercle. So here left side of your screen is the ulnar side. Okay, left side of your screen is the ulnar side. I will decrease the depth.
Boss, you change the setting to wrist and hand, it will be very nicely visible then.
Yeah, actually.
Yeah, MSK.
MSK, MSK. I think it is not. Oh, it is made. No, no, it is not made.
Press on MSK. Yeah, see
MSK.
wrist and hand has come.
Yes, yes, yes. Okay. Today Devjyoti is not there. His machine I'm handling. So okay. So this you can see this is the Lister tubercle where I'm keeping the probe in a short axis manner, in a transverse axis. I'm putting just over the radius and I can palpate also the Lister tubercle. So when you get the Lister tubercle, so already what you know. So let us see what we already know when we know that this is the Lister tubercle. Okay, so this is the Lister tubercle. So towards scaphoid, this side is toward radial side and this side is ulnar side. Radial side means this is towards scaphoid. Okay, and this is opposite side is ulnar side. So already we know that as I told you, so here this is the compartment number 2. This is the compartment number 2, Lister tubercle, radial side. And this is the compartment number 3. So what muscles, what tendons? These are all tendons because you can see there is no black colored muscles, no hypoechoic muscle or perimysium. You cannot see. These are all fibrillar structures. These are fibrillar structures and you can see clearly that these are all tendons. So third tendon means EPL. Second compartment tendon means ECRL and ECRB. Remember, all I am talking about from scaphoid side, okay, from this side to this side. So we are seeing ECRL first, here ECRL, then comes ECRB, and then I am coming EPL. Okay. Okay. So this is the same area. ECRL, ECRB, EPL. From the Lister tubercle, we have understood. Now let us see what is the compartment number 1. So it has to be, if right side it is compartment number 2, we will go more right to see the compartment number 1. So this is the compartment number 1 above the radial styloid process. So this is the compartment number 1. So what are the tendons? APL, EPB. Okay, APL and EPB. Both have P, so they are coming to the pollex. Okay, so in the thumb, they are coming to the thumb. So this is compartment number 1. Already I have shown you compartment number 3. So remember, compartment number 1 and compartment number 3 both have to come to the pollex. So what it will do? Compartment number 1, they are coming like this. Oh, okay, just a minute. Okay. Compartment number 1, they are coming like this, and compartment number 3. So that is also coming like this. Okay. And what is there in the compartment number 2? That means compartment number 2 is like this. Here you can see that compartment number 2 is there below, and it is traversed by both compartment number 1 and compartment number 3. কি করলি বাবা? চাদর আচ্ছা ঠিক আছে তাহলে এরকম রাখ। Okay. Okay, let us see again. So just see listed tubercle, right side compartment number 2, ECRL and ECRB. Now I will not freeze, I will just show you. ECRL, ECRB. I go to compartment number 1. APL and EPB. Okay. So let us see from here of compartment number 1 to compartment number 2. We can see the listed tubercle. Then comes compartment number 3. Now what is there? All other tendons. This is compartment number 4. Let us see. Means again I show you the listed tubercle area. Okay. Just a minute, let me. Okay. So compartment number 4. Compartment number 4. And as we can understand, this is the joint. This part is radius and this part is ulna. So this is the joint. Just above the joint there is a tendon. So this is compartment number 5. So compartment number 5 means extensor digiti minimi. Compartment number 4, here there are two different tendons. One is extensor digitorum with multiple slips. And another tendon is here, which is called extensor indicis. I think you remember extensor digitorum comes from above the elbow, whereas extensor indicis come from the forearm. Okay, so these are the tendons of 4 and 5, compartment number 4 and 5. Okay, so compartment number 4 and 5 already you have seen. So just under the yellow mark, it is the extensor indicis and extensor digitorum. There is a way how we can understand which is extensor digitorum and which is extensor indicis. Just if I go a bit proximally, extensor digitorum remains a tendon there also, but the extensor indicis becomes a muscle. So this part is extensor indicis, and these parts are extensor digitorum. Okay, so I have gone a bit proximally. Now as I come a bit distally, you see extensor digitorum indicis is below. Of course, after some time it has to go up, and gradually it goes up to the index finger. So here also there is a crossover between extensor indicis and extensor digitorum tendons, but of course that is not that important. So here fifth compartment, extensor digiti minimi. Let us see that whether what I am saying, extensor digiti minimi, dynamically that is true or not. So just a minute, so that you can see. No, you cannot see. Anyway, so just under the yellow mark, that is the extensor digiti minimi. কানি আঙ্গুলটা একটু ইয়ে করতো, হ্যাঁ। So you can see that he moves actively, extensor একটু বেশি করে রাখো, and extensor digiti minimi, that is also moving. Okay, anyway, so this is the compartment number 5. Now let us see the compartment number 6. So compartment number 6 is this much, this one, extensor carpi ulnaris. So this extensor carpi ulnaris is at the styloid process of ulna. So this is the extensor carpi ulnaris. So here, just under the yellow mark, you can see a clear tendon. So what the tendons which I have shown you, these are all short axis. These are all short axis. If we go proximally, then all the tendons will become muscle. Let's see, I show you that extensor carpi ulnaris is becoming a muscle. Can you see that already this part is the muscle part which is coming out? This part is tendon part. So when we go proximally, they become muscle, and this is the tendon. Now let us come to the again extensor. Already you have seen that extensor indicis becomes muscle, and extensor this one EPL also is becoming muscle. 3, compartment number 3, EPL. This is extensor indicis. So you have to remember how the tendon looks and how the muscle looks. Tendons are all fibrillar structure, hyperechoic. Muscle looks hypoechoic, a bit blackish structure. Okay. So if I go more up, then all the slips, they will also become muscles. They will also become muscles. So these are extensor digitorum muscles. Okay, slips, different slips. Of course, in this area, slips are started, but mainly slips you will see in the hand part only. So these are the tendinous slips going to different fingers. Okay, different metacarpals. Okay, I will remain in the wrist part only. So now comes the important pathologies which are related to your this knowledge of tendons. Okay, so we have already this is the starting area. Okay, so this is the home page. Whenever you are lost, you can come to the home page. So this is listed tubercle. Right side it is the 2, compartment number 2, and left side compartment number 3. Now let us see, as I showed you the picture, that ECRL, ECRB is in the compartment number 2, and it is always lying below, and it is straight coming and lying below, and it is covered by traversed by compartment number 1 and 3. So let us see. So let us see that whether I am correct or not. So here let us go for, so this is compartment number 2. You have already understood, listed tubercle, compartment number 2. I am going to the compartment number 1. So this is compartment number 1. Okay, this is above the styloid process of radius, and if I go proximally, then it should traverse over the compartment number 2. So do you think it is really going from radial side to ulnar side. So this one compartment is going above another. Okay, I think it is very clear, but still. Ah. So this is the ECRL, ECRB, and this is the compartment number 1. Gradually, it will pass from radial side to ulnar side, this side. Gradually, it will go this side. Okay. So remember, this is the compartment number 1 and 2. When I go proximally, it is passing from above the compartment number 2. So there is some area, say this area, you can see both tendons rub each other. Okay, both tendons are rubbing each other. Okay, one is traversing over another, both tendons are rubbing each other. Okay, so this is a area where patient can get pain and inflammation. So this area you can see, this tendon and this tendon is rubbing. So this is an area for tendinitis. So this is what we call as proximal intersection syndrome. Later I will show you in the PPT, but understand this part, that where the tendon of APL EPB rubs the tendon of ECRL ECRB, means 1 above 2. So this area is nothing but called the intersection syndrome, proximal intersection syndrome. Now we have already understood that this compartment number 1 and 3, 1 and 2. Another intersection, we have understood that this compartment number 2, it doesn't do anything, it stays there only, but everybody crosses it, means the compartment number 3 also crosses the compartment number 2. But where earlier I was going from the listed tubercle to proximally, now I will go from listed tubercle to a bit distally. See, if I go distally, then try to see that this EPL, compartment number 3 tendon, EPL, I think everyone can locate it. This is the EPL, compartment number 3. This is the scaphoid side, radial side, this is ulnar side. Okay, so this and ECRL, ECRB, compartment number 2. So by theory, after some time, it should go above it, because it will also traverse. No, compartment number 3 is also going above compartment number 2. So let's see whether it goes or not. So this was the compartment number 2, and now in this area it is traversing. In this area it is traversing. Okay, can you see clearly? This is the compartment number 3, EPL tendon. This is the ECRL ECRB tendon. Okay, so you can see, so this is also an area where one tendon rubs another tendon, and this is the area for distal intersection syndrome. Okay, so 2 intersection syndrome areas already I have talked about. Now compartment number, this was listed tubercle, and so this was compartment 2. I am coming more radial side. So this is the compartment number 1. Already you have understood that this is the APL EPB or compartment number 1. So here this is a position for all intervention here. Dr. Wafa was asking that from which side to which side we will give the injection if we have to. So remember, in this way I am holding the probe. So your injection, if it has to be in line with the under the ultrasound beam, okay, inline approach, then your injection has to go like this, from this side to opposite side, and it should be in line with the ultrasound beam. You will be able to see the whole needle. Okay. So here the all other thing, I mean, like when the way you will see the structure in this way only, you will go under the probe only in the same orientation, so that you can see the whole needle. That is inline approach. So here this is the two tendons, APL and EPB. Okay. So in dequervance tenosynovitis, it happens that you get a lot of fluid around the tendon. Here, some amount of fluid around all the tendons is acceptable, or it is a normal variation. Okay. Somebody has some amount, a bit more, or somebody has very less, but it is normal. And if there is dequervance tenosynovitis, then you will see a lot of fluid, and you can match with the opposite hand, and you will see that there is a variation. Okay, so here this is the APL EPB, and if I go a bit more distally, so what I will see? I will see the radial artery under the APL EPB tendon. Now I am not under the radius, I have come over the scaphoid bone. So again, I am going over the radius. All the interventions should be done over the radial styloid, otherwise you may puncture the vessel. Okay, so you can understand these vessels are big arteries are there under the two tendons. So already 1, 2, 3. Yeah, so two diseases you have understood: dequervant tenosynovitis and proximal and distal intersection syndrome. Now comes uh, what other things? Yes. So here one more important thing is superficial radial nerve. Superficial radial nerve, that is the sensory branch of radial nerve. Where should I search for it? I should search for it over the compartment number 1. So if it is the listed tubercle, this is under the yellow mark, this is the compartment number 2, and this is the compartment number 1. So here what is the important thing? When I come from the proximal side to distal side, so something in the subcutaneous plane should come from palmar side to dorsal side. So let's see it happens or not. Right side is the palmar side, and dorsal side, left side is the dorsal side. Okay, so when I will come from proximal to distal, something from the right side to go in the left side in the subcutaneous plane. Actually I can clearly see, so it is better I show you so that you can target this thing. So this is called superficial radial nerve. So as I go down, it will come above the compartment, so above the compartment 1 tendons. So here you can see, so here also you can see the superficial radial nerve. There is a honeycomb appearance. Now just under the yellow spot you can see the honeycomb appearance, clearly honeycomb appearance. Okay,
Sir, can we see the probe movement? Hand movement, probe position.
you cannot see.
The
And now I
hand
have
movements of the probe position.
a
That is
hand
not
movement.
visible.
Hand movement is so small
मतलब probe
that's,
position actually.
but probe position is not seen. You can see clearly. So this is over the compartment number 1, over the radial styloid process, and short axis I am holding the probe in the short axis. I mean
You tell, I
is there,
think boss, she's wanting to know how you have oriented your aspect marker. Is that what you want to know?
Yeah, yes, and movement like one overlapping is very much not clear if we are seeing the how probe is moving on the wrist simultaneously.
You want to know whether boss is moving the proximally or distally or side to
मतलब
side?
एक्चुअली या वो पिक्चर में अगर मुझे विजिबल होगा साथ में तो फिर आई थिंक इट
So
ज्यादा
picture,
क्लियर
But
होगा.
both the pictures and the USG images is visible side by side only.
it is live only.
It is
What I
live
am
only.
doing,
Maybe your net is having some issues, so one has stopped. Otherwise, both are moving simultaneously only.
नहीं
yeah,
यूएसजी पिक केवल यूएसजी पिक्चर एंड सर की पिक्चर दो टू पिक्चर्स आ रही हैं तीन थ्री पिक्चर्स नहीं है मैम.
थ्री पिक्चर्स क्यों होनी चाहिए? हम थ्री पिक्चर्स तो दिखाते नहीं. बॉस, आर यू ट्राइंग टू शो थ्री पिक्चर्स?
no, two pictures means I mean you are not seeing the patient's volunteer
या
picture.
यस
I am putting the probe on the volunteer's hand, that you are seeing or not?
नो दैट इज नॉट विजिबल.
Heh. For
For
others,
me, it is moving. It is moving, boss.
It is visible to us.
Yeah.
this is internet problem, slow internet.
Sir, it is visible.
Yeah.
मतलब सर आपकी पिक्चर विजिबल हो रही है हैंड एंड प्रोब की पोजीशन विजिबल नहीं है.
So मैं अभी बाकी तो हो रहा है सबको. मैं और थ्री
नहीं
पिक्चर्स
टू पिक्चर्स हैं एक आपकी पिक्चर आ रही है लाइव में और एक अल्ट्रासाउंड
अच्छा,
आ रहा है.
अभी मैं अपना पिक्चर बंद किया. अभी
पिक्चर भी आ रहा है.
आपको कितना पिक्चर दिख रहा है अभी?
अब एक वन.
अब एवरीवन, सबको दो दिख रहा है.
ओके ठीक है मैं एक बार दोबारा लॉग आउट होके दोबारा
ओके ओके ओके
कनेक्ट करती हूँ फिर. ओके
okay. How come this is possible? I don't know. Okay. Anyway, so internet thing is
Can you mark superficial radial nerve, sir?
okay. So I will little enough. I mean, it is so clear. Okay, this one. This is the superficial radial nerve. You try to see the honeycomb appearance also. So clear honeycomb appearance. When it is going just above the tendons, it is a bit flattened. It is a bit flattened. Okay. But again, after coming out from the that compartment, then again you can see the, just a minute. Then again we can see the honeycomb appearance a bit. Okay. No, just moved. So now this is honeycomb appearance. Okay, this is honeycomb appearance. This is the superficial radial nerve. Always try to see in a just subcutaneous plane. So this is the superficial radial nerve. When I'm going, so just above the tendons, it is flattened. Above the tendon, it is flattened. Again, as soon as I am coming, it is, so now also it is a bit flattened only. But then this is the way only. It will go in this way. So in one area I have already shown that this is the honeycomb appearance. So I think clearly it is seen. You can see, no, from proximal to distal, when you move, some structure will go from palmar side to dorsal side. Here it is the right side is palmar side, dorsal side is left side. So I am coming distal, proximal to distal, and you see this common superficial radial nerve from right side to left side, it is moving. Okay, so this is nothing but the superficial radial nerve. Here actually after some time it is visible. So this is the superficial radial nerve. I have come too much distal, but I think we can see. So this one. Okay, continuous tracing is sometimes not possible. Here it has come out, and again it will go above the tendon, and it has come out just under the yellow mark. So this is the superficial radial. Okay. Okay. So another, as I told you, that motor branch is there just between extensor 3 and 4, but not the full 4 compartment, about extensor indicis. So 3 is EPL. So I am again on the lister tubercle. So 3 is EPL and 4th is extensor indicis. Let me bring them. So under the yellow mark, this is the extensor, that is the EPL, so compartment number 3. Okay. Compartment number 3, EPL. Compartment number 4, but whole thing we don't need. We need only the compartment. Okay, compartment number 4. Say this is compartment number 4. So between them, our target area is this area. Okay, here just think, see carefully. You will see one artery and one small nerve. So this nerve is the dorsal interosseous nerve, and coming up to the wrist, but it is a motor nerve. So though for pain treatment purpose we don't need, but you should not injure. So just see. Can you see one artery pulsatile just under the yellow mark? I have kept it. In one side it is the compartment number 3, and one side compartment number 4. So this is the pulsatile artery, and just left to that there is a honeycomb appearance. So that is the dorsal interosseous nerve. I think this is clear enough. Okay. Okay. So till now, whatever I have shown, is there any confusion or anything? Otherwise, I will go to
Sir, can you show the 5, 6 compartments, sir?
5.
1, 2, 3, I can 1, 2, 3, 4, I can understand, but for 5,
Yes,
6 compartment.
Okay, 5, 6 compartments. So, okay, this is listed tubercle. 3, 4 we have understood. Let us see 5th compartment. 5th compartment is above radioulnar joint. Let us see the radioulnar joint first. So this is the radioulnar joint, most distal area. So here the 5th small dot, small round thing is there just under yellow mark. That is the extensor digiti minimi. If we move his hand actively, if he moves, then it will also move. Just a minute. Okay, this small tendon is moving. So this tendon is nothing but extensor digiti minimi. Okay. So remember, this is over the radioulnar joint.
Mark, sir. Please mark, sir. I'm still confused.
Okay, okay. Okay, because it is, I thought it is moving, so you will be seeing too much. Okay, so this is the radioulnar joint. Okay, radioulnar joint, just above that this small thing is extensor carpi ulnaris.
No, extensor
No, sir.
digiti minimi.
Extensor digiti minimi.
Actually, extensor digiti minimi. Yes, I am becoming sleepy. Okay, yes, extensor digiti minimi. This is compartment number 5. Extensor digiti minimi. Okay, so now you can see, I think, isn't it? Just above the radioulnar joint, extensor digiti minimi. Okay, I think this much. This is clear only. I mean, Okay, another thing, when we are seeing this extensor digiti minimi and we are seeing the distal radioulnar joint, we should go a bit proximal to see that if there is any effusion. For arthritis cases, not in these cases, for arthritis cases. So here, this is, we are seeing the tendon, but we should go a bit proximally to see if there is any fluid accumulation, because this is the, if there is an effusion, fluid accumulation occurs a bit proximally and not at exactly the end point of radio ulnar joint. Okay. So, and this is the compartment number 6. So compartment number 6 is actually very easy to find. I mean, but without any, I mean, you don't have to walk from the compartment number 2, 3 or see listed tubercle. You just see the ulna in short axis and just go up, and you will find that there is a groove type of thing. So this groove is nothing but extensor carpi ulnaris. That's it. This is the extensor carpi ulnaris. So this is the compartment number 6. Okay. So this is the extensor carpi ulnaris. Okay. Now comes what is there? Okay. Second thing, as I told you, small ligaments. So one ligament is scapholunate ligament. Scapholunate ligament. So we can understand as this is the proximal line. She looks too pretty. Try to catch her. So scaphoid, lunate, triquetrum, and pisiform. So scapholunate joint from this side, radial side to ulnar side. Okay. So how we will find it? So let us go to the, again in the listed tubercle area. From listed tubercle area, let us go to the dorsal intersection area. While going to the distal intersection area. Distal intersection means compartment number 3 tendon will go above the compartment number 2 tendon. EPL will go above ECRL, ECRB. So while going there, you just see the bony margins. Then we will be able to find the scapholunate joint. So I am going, try to see. So already distal intersection area has come, and below you can see two bony margins, two different a different type of bony margin below. I'll make the depth a bit more. Depth. Okay. So this is nothing but the scapholunate joint. Okay, this is the scapholunate joint. And I can show you the ligament also. So this is scaphoid, this is lunate, and this is the scapholunate ligament. You see there is a small fibrillar structure. So this is called scapholunate ligament. Okay, scaphoid lunate. For a dynamic examination, here he is not a patient, and he, since I mean for him it is always normal, but as a dynamic, for dynamic examination, if you try and think that there may be an injury, so you will stretch the ligament just by ulnar deviation. Just by ulnar deviation you will stretch the ligament, stretch the joint. So if there is a opening, I mean it opens up, then you will know that maybe this ligament is torn. If of course patient comes with a pain in this area, then only. Okay, so you can see the ligament very clearly, scapholunate ligament. Any confusion? Fibrillar structure also can be seen. I mean, oh, My volunteer is falling down. He is so sleepy. I mean, so this is the ligament, scapholunate. Okay. Now let us see the lunotriquetral ligament. So lunotriquetral is just first we will find the scapholunate and we will go laterally. So this is the lunotriquetral area. But of course, ligament wise, just a minute. Lunate, triquetral. So this is the lunotriquetral area. Ligament is not very clear, but still, but this is the lunotriquetral. Ah. So this is the lunotriquetral area. This is the ligament. Okay. So these are small ligaments. Only these two ligaments are all right. If I put in the middle finger, over the middle finger, if I put the probe in a long axis manner, so in this way. So what are the bones? Already I showed you the picture. So left side, it is the radius. Left side radius. In between, it is the lunate. Radius, lunate, and then comes capitate, and then comes metacarpal starting. So you see the typical typical bony margin of lunate and capitate. Okay, capitate, as I told you, that it is like T type. It is a long bone. So this is the long bone, capitate. And lunate, it is like a hill type. So this is now under the yellow mark, it is the lunate. Lunate, and then this is capitate. Okay, lunate, and this is capitate. In one side it is the radius, and in other side it is the metacarpal, second metacarpal. Okay, so just a minute. Okay.
Doctor, there is no sound.
Sorry. Okay, I did not show you the extensor retinaculum. So extensor retinaculum is seen in that area where the compartment 4 is seen clearly. Okay, so here again let us see listed tubercle. I'm holding it opposite way. So listed tubercle. Right side is your compartment 2, listed tubercle under the yellow mark, 3, and this is 4. So we will see all the sleeves here, all the sleeves. Okay. Now after we have seen all the sleeves clearly, I will move the probe towards the radius a bit obliquely. So this is always not hyperechoic, but still you can see. So after I have seen all the sleeves of extensor digitorum, I made one side go towards the radius. So I can see now. So this is the extensor retinaculum. Okay. So this is the extensor retinaculum. This extensor retinaculum actually has multiple sleeves which come and join in different bones. Here also extensor retinaculum. These are extensor retinaculum only. So you see, it looks like you will understand that there is a different structure. So how to find it? First, we will see all the sleeves of extensor digitorum. Then I am moving one side towards radius. Okay. So this is just above that you can find extensor retinaculum. So this area is extensor retinaculum. From here also actually you can go. This is better. So this is the area where now the fibers are much better that it is going and inserting the same area just above the tendon, the hypoechoic area, but the fibers you can see just going down and inserting over the radius. This is the radius lower part. Okay. If you are not understanding, okay. This is the radial head. Okay, this is the bone, and these are extensor retinaculum. Okay.
Sir, below the extensor retinaculum, what is the tendon, sir? Below the
Uh-huh.
extensor, below the extensor retinaculum, one
Yeah,
is
it is all the extensor digitorum. Quadrant number 4, compartment number 4, extensor digitorum.
okay, sir. Okay.
Okay.
And excuse me, doctor, what bone under the compartment number 4 unit?
So where you are seeing, that is the thing. I mean, if you go distally, then it will be the all metacarpals. Sleeves have come and metacarpals will start. And if you remain over the what should I say, a distal part of radius and ulna, then you are over the radius only. Like I can show you. See, Lister tubercle is a part of radius. So here you can see there is no cortical break. The whole surface of radius you are seeing, and this is ulnar, radio ulnar joint. Just above that, this is compartment number 4. So all the compartment number above the radio ulnar joint, this is compartment number 5. Okay. So extensor digiti minimi, and all the compartment number 4 tendons, these are compartment number 4 tendons, not this one 3. Okay. So this is 4. So they are above the same bone, same bone. Okay. So this is radius. So this is radius. You can see the whole, all the tendons over the radius. And this is ulna. So it depends where you are seeing. That is what. Okay. So I think already understood. Any other thing? Oh, TFCC. I have not shown you the TFCC. So last thing from my side, It is TFCC. But anything else you want to see, I will show, and I will ask you some questions also. Let's see how much you can memorize, because few things you must memorize. There is no other option, like which compartment has which tendon. Okay. একটু এরকম রাখ। Okay. So এটা কি নড়ছে? না তোর হাত ওইটা লাগছে না তো? Okay. So here TFCC, for seeing TFCC, you see extensor carpi ulnaris. So we are seeing extensor carpi ulnaris. Let us see the extensor carpi ulnaris in a long axis. So we already showed you, we already so you can see that extensor carpi ulnaris tendon. I want to bring it in a full long axis view. I can make it more, yeah. Okay. So okay. So here what we are seeing, extensor carpi ulnaris. And the area, so this area is filled by the TFCC complex. TFCC complex. Okay. So our main fibrocartilage is this one. Of course, this one also. So when we will look in these areas, if there is a tear or there is a fluid collection, then we will say that it is not a normal TFCC. For ultrasound, we can say only normal or abnormal only in this part. MRI is the gold standard for this, and we cannot see the whole part. Okay. So for seeing TFCC, the main thing is you see the extensor carpi ulnaris in a long axis, and you can see the whole this triangular fibrocartilage. Okay. So this white colored cartilage is triangular fibrocartilage, this hyperechoic area, Okay. So just I show you stop share screen. Pathology. Just 2-3 slides about the pathology. So already I talked about these things. What are the causes? I told you dequervent stenosynovitis, extensor tendinitis, intersection syndrome. So dequervent stenosynovitis, please answer some. I will ask someone. So anyone can answer. Okay, dequervent stenosynovitis is related to which tendon?
First compartment.
First compartment.
Yes, two tendons are there. Please say the names.
Abductor pollicis longus and extensor pollicis brevis.
Yes, APL, EPB. Okay. Extensor tendinitis can occur anywhere, all the extensor tendons, that is, it is possible. Intersection syndrome, proximal intersection means rubbing between which tendons?
1 and 2.
Yes. So what are the tendon names?
One is the adductor pollicis longus and the extensor pollicis brevis, and 2 is the extensor carpi radialis brevis and longus.
Longus and brevis, if you come from the scaphoid side, then it will be like that. ECRL, ECRB. And okay, distal intersection is between which are the tendons?
2 and 3 compartments, sir.
So which one is above and which one is below?
Above is third compartment, sir. Third extensor pollicis longus.
Yes, EPL, extensor pollicis longus, is above ECRL and ECRB. Okay. This thing I will just tell. Okay. So already we have showed it. So here, as you understand, so this is the extensor carpi radialis brevis. The second compartment is like that, and everything is 3 also and 1 also. They are in some way they are traversing them. So when patient comes to you, this is the presentation for dequervent stenosynovitis. In one side, you can just palpate. There is always a pinpoint pain. And if it is an intersection syndrome, then pain is on the dorsal side, not at the one side or the compartment 1. So it always matches with the compartment. So this is a picture of only dequervent stenosynovitis. Okay, so this is ganglion. Ganglion, there are different sources of the fluid. It can be from the joint also. It can be from the tendon sheet also. Okay, in all the cases, of course, more accept, nobody knows actually the origin. 100% it is not known, but the fluid, it can come from the joint and can come from the tendon sheet, but we can aspirate and give a steroid injection. It gives nearly 100% success. Okay, so these are ganglion. Posterior side dorsal compartment is the most important area where we find the ganglion. Scapholunate ligament area, so those area is most important area for ganglion. When we see the bones, then we also try to see that what we try to see, we see the margins of the bones. Okay, in the posterior side also, in a rheumatoid arthritis cases, we will always see the margin, articular surface of the bones, of the carpal bones. So there can be a bone erosion, there can be osteophyte type of bone coming out, or there can be a gap, cortical defects. Okay, so erosion, cortical defects, these are possible. So you can see this is the, as I just showed you, lunate capitate area. So this is the most common area to show in a rheumatoid arthritis case, that whether the margin of the bone is normal or it is like there is a gap. So here we can see, of course, synovial hypertrophy also. Many times we can see, many times we cannot see. Okay. Then comes, so here, as I told you, that here compartment number 5 is seen over the radio ulnar head at the last part. But if you want to see an effusion, then you go a bit proximally, where radius and ulna still have not joined. It is the ulnar neck, not the head. So in this area, you will find the effusion if there is a radio-ulnar joint effusion. This is a case which I did for this one, Wartenberg syndrome or chiralgia paresthetica, and for means it is the for superficial radial nerve entrapment, but in my case it was a neuroma, schwannoma, or neuroma, you can say neuroma. So you see the picture. This is the compartment number 1. This is the compartment number 1, which is going just above the compartment number 2. So compartment number 1 is going above the compartment number 2, and in subcutaneous plane there is a neuroma. This black thing is a neuroma, and it is in the subcutaneous plane. And I am just giving the local anesthetic infiltration to diagnose that whether patient gets good relief or not. So this patient got very good relief, but of course, we advised cryoanalgesia, but he did not come. Anyway, so any other thing? No, nothing else. So anyone wants to ask any question? Is there any confusion in today's class? Okay then. So dorsal wrist this much only. You see the recording, and mainly it is not about memorizing.
What do you give, sir, for decuevance?
What?
Decuevance stenosis. What injection?
Dequervus tenosynovitis is most of the time it is an acute presentation, and we go for steroid injection. Yeah.
How much ml?
Maximum 1 ml or 1.5 ml. It doesn't go more than that.
Thank you.
20 mg, maximum 20 mg steroid in 1.5 ml volume. Yeah, that much enough. So any other question?
Sir, the superficial retina you are showing it is big size, sir. Actually, it is small nerve, sir.
I showed you a neuroma. During yeah, I mean demonstration.
Yes, sir. It is feels like a big size, sir.
No,
Actually,
it is about the quality of your machine. If machine is good, then I have seen that it is so beautifully seen. And I mean, this is my experience also. I mean, if it is a very high quality machine, things are much easier. Very nicely it is seen. It is like that only.
and in the elbow, we have seen the median nerve is very small compared. It is small, sir. Previous videos, sir. In elbow, median nerve is very small.
Median nerve.
Sir. I am asking that is compared to today radial nerve and the previous median nerve is it is very different, sir.
I could not get you.
Okay, sir. I can understand, sir. What you said, I understand.
Kanchan, did you understand what he's
Yes,
saying?
I understand, sir. I understand, sir. I understand.
Okay.
Actually, he is just trying to tell that median nerve he could see very small in elbow, and it is much bigger, the superficial radial nerve. So is he thinking, is it absolutely, a
Yes,
problem
sir.
with the
Yes,
nerve
madam.
itself?
Yes, madam.
That's
My
what
question.
he's trying to ask.
Okay. Okay then. I think it's okay. So good night for today. Okay.